So students, in continuation, today we will discuss another disease of the colon called diverticulosis. Okay, so what is diverticulosis? See, it's an pouching in the GI tract somewhere through the wall of the intestine. The commonest site of diverticulosis is sigmoid colon. Okay, sigmoid colon. There are two types of diverticulosis. One is true diverticular, another is false diverticular. True diverticular means it has all the layers of the bowel wall. That is mucosa, submucosa, muscular layer, serosa. It has all the layers of the bowel wall. It is also called congenital diverticulum. Okay, as in Meckel's diverticulum. It's a true diverticulum. Whereas false diverticular, there is mucosa and submucosa penetrates the muscular layer and comes out. It has only mucosa, submucosa. It doesn't have all the layers. Okay, as in colonic diverticulosis. This is a false diverticular or acquired diverticular. Okay. So what is the etiology of diverticulosis? Why does diverticular occur? It's mostly seen in elderly age group patients, those with the Western diet like refined diet and less fiber and more carbohydrate and all. What happens that the increased pressure is generated, especially in sigmoid colon, because sigmoid colon is the narrowest part of the colon and it has tinea coli. So in between the tinea coli, where the vessels perforate to supply the bowel wall, that's the site of the weakness. Okay, in between the tinea, where the blood vessels penetrate the wall to supply the bowel wall, that's the site of the weakness, and through them, if the increased intraluminal pressure is generated, diverticulum occurs. You can see it occur from inside. It looks like a hole here. You can see it looks like a hole. So commonest site is sigmoid colon, and because of the increased intraluminal pressure, it's sort of a Pulsian diverticulum. It pushes the mucosa, submucosa out. So what it can cause? These diverticula can become inflamed and give rise to diverticulitis. So the patient will have pain abdomen. Okay, pain abdomen, patient can have fever. These diverticula sometimes can bleed and lead to hemorrhage, bleeding. These diverticula can also perforate, and perforation will lead to a small abscess, and then that abscess, if not treated properly, it can lead to pelvic abscess and purulent peritonitis and then fecal peritonitis. Okay, so a diverticular can lead to perforation, obstruction with a band and all, bleeding, and it can lead to abscess formation. Sometimes if prolonged diverticulum is there, it gets attached to the surrounding structures like uterus and vagina in female, bladder in male, and can lead to colovesical or colovaginal fistulae as well. Okay, so these things it can lead to. So these are the complications of diverticula. Also, there is a one Hanche classification, Hanche staging of diverticula. Stage 1 is when little perforation has occurred, which is contained. Perforation has occurred in the diverticulum, which is contained along the bowel wall. This is stage 1. When it leads to pelvic abscess, it is stage 2. When it leads to purulent peritonitis all over abdomen, it is stage 3. And subsequently, when it leads to even fecal peritonitis, that is whole abdomen is filled with feces, it is called stage 4 or fecal peritonitis. Okay, so these are the stages of diverticulosis. Now, how do we treat diverticulitis? See, in early stages, a patient comes to you with pain and all, then of course we have to make a diagnosis. So first let's discuss diagnosis. How will you diagnose diverticulitis? The diagnosis is done mostly age factor, classical history of pain, constipation and all, patient having tenderness in the left iliac fossa, fever, high leukocyte count. Then you will subject patient to CT scan. We do a CT scan, and that will show you the diverticuli, and if there is any abscess or collection, that will show that as well. So CT is the investigation of choice here. We don't do colonoscopy in acute stage, because it will be very painful and it can lead to perforation of the diverticula. So colonoscopy is contraindicated in acute diverticulitis. Later on, once patient responds and in the remission phase, then you can do colonoscopy. Okay, barium enema is also not done. So this is how you investigate, and obviously you will do CBC, C-reactive protein, ESR, and all those tests which you do normally. So this is how you diagnose diverticulitis. In first, we will in stage 1 and 2, conservative treatment is given. That is, patient is admitted to the hospital, is started on IV fluid, a broad spectrum antibiotic like third generation cephalosporin or piperacillin tazobactam plus metronidazole or meropenem plus metronidazole. Is also given analgesic, okay, put nil orally for few days, and then a patient should respond on these. But if widespread peritonitis has occurred, like purulent peritonitis and fecal peritonitis, then obviously these patients will need surgery. So indications of surgery will be failure of conservative treatment, purulent peritonitis, fecal peritonitis, and of course we have complications like if perforation and bleeding has occurred, obstruction has occurred, things like that. So what do we do in surgery? We usually open the abdomen with low and midline incision. We see the sigmoid colon, you will see the outpouchings there, collection there. Okay, we have to wash it out and have to do sigmoid colectomy. Sigmoid colon is the site bearing the diverticulitis, so we resect the sigmoid colon, and if sepsis is there, we will do a proximal end colostomy and close the distal rectal stump. This is called Hartman's procedure. This is widely used in an emergency. Whenever a patient lands to you and you do an emergency surgery, it's advisable to not to do primary anastomosis, as this has got increased chances of leakage and patient will have leakage from anastomosis. So we'll better resect the part, then do an end colostomy, proximal end colostomy, and distal stump is closed. This is called Hartman procedure. Then we'll reverse it. Otherwise, if sepsis is not that severe, we can, if elective operation is done in the quiescent or remission period, then we can do sigmoid colectomy and end-to-end anastomosis. Okay, so this is how you treat diverticulitis. Next class, I will tell you about colostomy. Thank you.